to Grand Rounds and welcome to an audience. I'm sure be here to hear Dr. Schon today. It's a pleasure to introduce Emma Schon, who's now completing her fellowship in critical care, but completed medicine here at UBC. And Emma and I had a chance to work together, and it was really enjoyable. And I'm delighted that she's presenting today. I neglected to mention that the acknowledgement, the land acknowledgement for on the traditional and ancestral unceded territories of the Coast Salish peoples. Dr. Schon's topic today is the withholding and withdrawing life-sustaining treatment, pertinent to us all. Emma.
Thanks, Ray. Okay, so I'll get started. Thanks everyone for coming. I'm really excited to be here to talk to you about this topic today. So I also have a land acknowledgement here. For my disclosures, I have no industry conflicts of interest to disclose, but do have some research support I just wanted to acknowledge. Myself and our research group received a grant from the Pan-Canadian Palliative Care Research Collaborative for our research, and we also have support from Providence Healthcare Palliative Care Program and St. Paul's Hospital Foundation. So for the objectives of the talk, I hope by the end, everyone can understand some of the differences between withholding and withdrawing life-sustaining treatments. I hope that we can all become familiar with some of the Canadian policies on this topic, and then specifically our St. Paul's Hospital policy on code status. And then I hope that by the end, we can all understand the importance of serious illness conversations in caring for patients at the end of life and preventing some of these conflicts that can arise between healthcare providers, patients, and their families. So to begin, what is a life-sustaining treatment? So this is either a medication, such as a vasopressor, or a medical device, such as a breathing machine, a CRT machine, that supports or replaces vital organ function. And so when we talk about withholding versus withdrawing, it is usually with the goal of the patient eventually passing away naturally from their underlying disease or related complications. And so although medications may be given in this scenario for comfort or to relieve suffering, the intention is not for these medications themselves to cause death, but rather for the patient to pass away naturally from their underlying disease process. And so this is something that really differentiates withholding and withdrawing life-sustaining treatments from something like MAID or medical assistance in dying. And so just to be clear, we're talking about withholding and withdrawing life-sustaining treatments in the context of patients who are frail, who are comorbid, and who have advanced serious illness, where there's generally a medical consensus that advancing care or providing treatments would be non-beneficial and potentially harmful or inappropriate for the patient. And so these conversations are difficult to have with our patients because we have to be able to understand, one, their prognosis, and then two, how likely we think they are to benefit from these interventions that we have to offer. And we have to be able to align what the patient wants with what we think is appropriate as the medical expert. And so to do this, we need to have a series of serious illness conversations between the healthcare team and the patient. And so a serious illness conversation, we've all heard of this before, is generally a conversation that happens between care team and the patient and their family about a patient's understanding of their illness, their preferences around how they want to receive information and how much information to receive, their understanding of their prognosis, their goals, fears, and acceptable trade-offs. And so these conversations should occur early in the course of a serious illness, and they should occur over time and be reassessed frequently. When we talk about a serious illness, this can mean many things. So it can mean somebody with metastatic cancer. It could be somebody with advanced medical comorbidities, such as COPD on home oxygen or end-stage CHF, chronic kidney disease on dialysis. A serious illness can also mean somebody with functional decline and significant frailty. And then the other thing I use to sort of gauge whether or not I should be having a serious illness conversation with a patient is I ask myself, if I wouldn't be surprised if this patient passed in the next, let's say, 6 to 12 months, then that should be somebody that we're having an early serious illness conversation with. Now, one of the outcomes of a serious illness conversation is a patient's goals of care. And so we should be able to understand what the patient's values and wishes are while the patient is still well enough to communicate these to us so that they can be shared with care team, family, and then documented in the chart. And so these goals can be personal, they can be health related. They could be things like, I want to survive until the birth of my grandchild in 3 months. And they could be broad, like I want to make sure that at the end of life, I have control and I'm as close to my truest self as I can be. And so it's important to document these goals and wishes for patients. And then finally, the last kind of outcome from a serious illness conversation is an actual code status or MOST status. And so this is something that I believe as physicians, we should provide as a recommendation to patients and not necessarily give them kind of a list of options, but rather based on their goals of care, provide a recommendation about what we feel is an appropriate code status for them. And so as a patient has advancing illness and progression of their underlying comorbidities, these conversations around serious illness conversations and goals of care become even more important. These conversations are obviously challenging though. They're hard because we have to be able to have good communication skills with patients and their families. We need to talk about difficult topics like death and the end of life. We need to be able to engage in shared decision-making and be able to communicate sort of complex medical information in a clear way that patients and families can understand. And so aside from kind of these more like soft skills that we need to have, be able to do for patients, there's also a lot of medical expertise that we need to actually be able to prognosticate a patient's medical disease and understand kind of their trajectory moving forward. You also need to have an understanding of the actual critical care experience for a patient and then the post-critical care experience. And so this is challenging even for those of us that work in the ICU. And so of course, for residents and physicians who work maybe in a more of a ward setting, it's hard to really understand the nature of what happens in an ICU and in the post-ICU experience. And so this article up here was published, I think last month actually in NEJM, called Outcomes After Critical Illness. And it basically was a review of all of the studies and critical illness literature that came out in the COVID era and looked at some of the outcomes for critical illness and impacts on patients. And there's this good schematic that kind of outlines for patient, family, and healthcare provider some of the post-ICU comorbidities that arise. And so importantly for the patient, there's things like pressure sores, cognitive dysfunction, oral injuries, critical illness, polyneuropathy, and significant deconditioning resulting in functional dependence. And so all of these things are parts of an ICU experience that inevitably happen over time and should be understood by us as care providers and then communicated to patients and families. This is a great graph from that same paper that basically takes patients and kind of classifies them as like patient A, B, and C, and classifies them based on their pre-ICU level of functional capacity and a kind of like number of comorbidities. And basically what it shows is that over time, after an ICU experience or an ICU stay, out of around 1 year follow-up, no one has returned to their pre-ICU level of function. And so this is a very important point and something that I try to communicate to all patients and families when having goals of care conversations, is that basically regardless of how functional you were before, after an ICU stay, we do not return back to that same baseline. And so as we're seeing patients with increasing severity of illness admitted to CTU, admitted to the wards, admitted to the ICU, we are having to balance the multiple comorbidities that they have and all of the advances in technology that allow us to care for these patients. And ultimately, something I end up communicating to families is that there's a lot that we can do in medicine, right? We can put you on a ventilator, we can put you on CRT, we can support your blood pressure. There's lots of things that we can do, but it doesn't always mean that we should. And it doesn't always mean it's the right thing for the patient. And so it's being able to find out as physicians and care providers, which patients are truly going to benefit from all that we have to offer and who should be offered these kind of life-saving or sustaining interventions. Because a lot of things that we do they are not benign. So coming to the ICU is a very aggressive intervention, and it's not benign, just like CPR is something that is not benign and often not effective. So as we know, if someone has good CPR, patients often develop rib fractures, pneumothoraces, and if they eventually survive, they're often left with significant pain, suffering, difficulty weaning from the ventilator. So there's a study published in the CMAJ out of Edmonton, and they looked at in-hospital cardiac and respiratory arrests, and they classified them as either witnessed or unwitnessed and looked at the outcomes for these patients. And what they found was of unwitnessed in-hospital arrests, about 21% of patients got ROSC. and about 1% of patients survived a hospital discharge. And so these numbers are important because this is an inpatient setting where there is a code team, there's trained healthcare providers who check regularly on patients, and this is how poor the outcomes are. And so if we imagine all the out-of-hospital cardiac arrests that we see and how poor their survival is in comparison to this. So when it comes to making these decisions, in medicine, we're generally moving away from this paternalistic or parental method of decision-making where physicians kind of dictate the direction of care. And there's some evidence to show that that's actually the preference of substitute decision makers, specifically in an ICU setting, is that of shared decision-making. And so there was a Canadian study that looked at 6 different ICUs and the experience of substitute decision makers when caring for patients admitted to the ICU. And basically it found that shared decision-making was preferred by 84% of substitute decision makers when their loved ones were in the ICU. Of the remainder of that 16%, about 15% wanted the physicians actually just decide on their own. And only about 1% wanted to make the decision just on their own without much input from physicians. And so what this shows us is that we need to be able to have these conversations and support families in making these difficult decisions. Now, in order to make that easier for ourselves, we have to have these early serious illness conversations where we can sort of set the stage for families and patients about what's to be expected in someone's critical care course or in the course of their serious illness. So when we look at serious illness conversations, there's a study that was published in JAMA in 2008 that looked at patients with advanced cancer and looked at patient and caregiver outcomes. And basically, the goal of the study was to determine what impact end-of-life discussions had on the level of treatment and intervention that was offered and how that end-of-life process impacted patients and caregivers. And so what they found was that when serious illness conversations were had early, it resulted in less aggressive care at the end of life. And then this was in turn associated with a higher patient-reported quality of life and, interestingly, higher caregiver quality of life in the bereavement period. And so having these conversations early creates better reported quality of life for patients and families both. Again, highlighting the importance of having these serious illness conversations. So we'll stop for a moment and just talk about one of the big legal cases that sets a lot of precedent for how we make decisions around these topics. And that was the case of Mr. Rasuli. So this occurred in Ontario between 2010 and 2014. Mr. Rasuli had a benign brain tumor that was resected, but unfortunately complicated by a post-operative infection and meningitis. He was in a minimally conscious state and basically required trach, PEG, and ongoing life support to maintain his life. After many months, the physicians concluded that there was no reasonable hope for recovery and that life-sustaining treatments were inappropriate, and they recommended the withdrawal of these and movement towards palliative care. So the patient's substitute decision maker applied to the Ontario Superior Court of Justice to prevent the removal of these life-sustaining treatments. But the judge actually found that no injunction was required and that the physicians actually needed consent to withdraw life-sustaining treatments per the definition of treatment under the Health Care Act. So the physicians then appealed this to the Ontario Court of Appeal and eventually to the Supreme Court of Canada. And they argued that consent should not be required to withhold or withdraw treatment that's outside the standard of care. And they argued that requiring physicians to provide non-beneficial treatment that may actually place the patient at risk of harm would put physicians kind of in breach of our professional duties. Despite this appeal, however, the Supreme Court dismissed their case in a 5-2 decision and basically said that based on the interpretation of the Health Care Act, consent is required for withdrawal of treatment in the case specifics of the Rasuli case. So these details were, so consent would be required to withdraw treatment when it implies the administration of another treatment. And so in this case, when you're then providing palliative care after removal of life-sustaining treatments. Consent would be required prior to withdrawal of treatment when it requires physical contact with the patient thereafter, and when the likelihood of death is high after the withdrawal of treatment. And so these are important kind of points to recognize from the Rasuli case when consent was deemed to be required. It's also important to recognize some of the limitations of this case because while it addressed and answered certain questions, it didn't address and answer a few things. So it didn't talk about the difference between withholding versus withdrawing. It did not definitively state how the standard of care actually impacts the need for consent. And it's really unclear how this case would apply outside of those specific points that I mentioned on the last slide of the Rasuli case. And so we often rely on this practically to say that we need consent to withdraw care, but ultimately there are very specific points of this case, and other cases just haven't been challenged like it. So we'll just pause for a minute and talk about a case that comes up frequently and some strategies that we can use to deal with families in these scenarios. So if you imagine the case of a gentleman in his 80s, say he comes from home where he is able to live independently, but with significant supports. Maybe he mobilizes around the house with a walker, can do most ADLs, but not IADLs. He has many comorbidities such as cardiac disease, AFib, severe COPD. And now he comes into CTU and is admitted with a pneumonia. He's documented as a full code and has increasing oxygen requirements, so eventually gets transferred to the ICU for mechanical ventilation. And so in cases like this, sure, it's possible that this 80-year-old gentleman with multiple comorbidities could survive the ICU stay, but there are also probably more likely outcomes, which include a prolonged hospital stay or death. And so when I have the luxury of time to meet families and speak with them over time, I like to usually paint some scenarios for them. So I usually start with the best case scenario. So what I hope for your loved one is that after a short ICU stay, they can recover.
Can you ask them just to mute themselves?
Oh, can whoever's on the line just mute themselves, please? Thanks. And so I like to outline the best case scenario. So I hope that your loved one is able to leave the ICU. I don't know how to tell who it is.
It's Dr. Amar.
Okay.
You can just say.
Should I call him out?
Yeah.
Dr. Amar, could you please mute your microphone? Perfect. Okay. So again, the best case scenario is that your loved one can return home with a lower level of function than they had previously, but that they can return home. Then I say another possible scenario is that your loved one has a prolonged hospital stay and eventually requires long-term care and dependent living for the rest of their life. And then finally, the last case scenario is that your loved one continues to develop complications of their hospital stay and eventually dies in hospital. And so I find it helpful to lay out these scenarios for families and say, right now, I hope that we get to that best case scenario, but there may come a time when the patient's been admitted for weeks and months maybe, and that best case scenario becomes impossible, and we're only working with these other case scenarios. And so when I go back to families and say, hey, we're at that moment where I don't think that best case scenario is going to be possible, and now we're dealing with these other options, it kind of bridges us into conversations around end of life and withdrawal of care that we are starting to see is futile. So in these tricky scenarios where we're working with families around end of life, there are certain guidelines and policies that we can refer to help us with decision making. And so I'll review those now. Interestingly, the College of Physicians and Surgeons of BC doesn't actually have a policy on withholding and withdrawing life-sustaining treatments. There are many other provincial colleges that do. So in Ontario, Manitoba, and Alberta, they all have policies on this topic. But here in BC, we don't have one. So St. Paul's Hospital actually recently made a policy on this, which I'll review after this. But it's based mostly on the Canadian Critical Care Society and the Canadian Medical Association policies. And there's also this American Thoracic Society policy with like multiple other international bodies with a good position paper on the topic. So to review here, in the setting of disagreement between families who are wanting escalation of care and a medical team that deems this to be inappropriate, there are certain steps the Canadian Critical Care Society recommends that we follow. And so first, obviously, maintain good communication. Implement a shared decision-making process and involve the substitute decision maker in conversations and decisions. Reach a medical consensus. And so this implies that second medical opinions should be obtained and documented in the chart. Involve a multidisciplinary team. And so this can mean other consultants, other opinions, ethics, risk management, spiritual care. And then finally, the policy states that if treatment is not medically effective and is not in accordance with the standard of care, then the physician is not obliged to begin, continue, or maintain the treatment. So Similarly, in the Canadian Medical Association policy on this topic, very similar themes come up. So attempt to resolve a disagreement early. Try not to have it escalate to the point of legal involvement. Obtain a second medical opinion. And then ultimately, the same final statement. When there is clinical consensus that a life-sustaining intervention is medically futile, then that intervention need not be offered and can be withdrawn when it has already been put in place. So based on the CMA and the CCCS guidelines here, our St. Paul's Hospital Advanced Care Planning Committee created our own policy on the topic. So there's two policies here. One is our code status options for care policy, which was just revised in the fall. And then we have an advanced care planning and serious illness conversations policy. So I'm going to review the first one today. So our code status policy here at St. Paul's outlines a few things. It outlines when to review a patient's code status in an acute care setting. It outlines when a do not resuscitate is appropriate. It outlines how to deal with temporary changes in code status, say when a patient's going for a procedure or a surgery. And then it talks about dispute resolving mechanisms in the setting of disagreement between patient, family, and the healthcare team. And that's what I'll focus on now. So generally, I break this up into prior to escalation of care and once escalation of care has already begun. So prior to escalation of care, so this patient would be a patient admitted to CTU on the ward who may be decompensating or potentially declining. So in this setting, when the healthcare provider does not feel like it's appropriate to escalate care further, they should always seek a second medical opinion and ensure there's medical consensus that escalation of care would be non-beneficial. Risk management should be involved in every scenario where there's a disagreement between family and healthcare team. We can consider involving ethics to weigh in. And then ultimately, the substitute decision maker should be advised that escalation of care will not be provided. This should be documented in the chart, and then the code status can be changed unilaterally by the physician. The substitute decision maker can be advised that they can seek legal action through an injunction if they wish. But these would be the steps to follow for a patient prior to escalation of care if it was felt that further escalation was non-beneficial. Now, in the scenario where escalation of care has already occurred, the patient had a code called, they get intubated, and they come down to the ICU and are receiving full life support. If it's felt that ongoing care is not beneficial and potentially harmful to the patient by the healthcare team, but if the family believes they want to continue, similar steps should be followed. So a second medical opinion should be obtained. Risk management should be involved, again, in any case where there's disagreements between the family and the healthcare team. Ethics could be involved. And then essentially the substitute decision maker should be advised that a code status will be maintained as is for 48 to 72 hours or enough time, like 2 to 3 business days, for them to go to the courts and obtain an injunction to continue care as requested. And if in that time frame, there is no action taken by the substitute decision maker, then the code status can be unilaterally changed by the physician. And so as you see in both those Canadian policies and our St. Paul's policy, there is support for not providing or for withdrawing care that is not deemed to be beneficial. The caveat is here that from a legal perspective, these guidelines do not necessarily provide legal protection. And in practice, most people practice based on the findings of the Rasuli case, which is that we do need consent to actually withdraw care. So again, we'll take a moment and just talk through a case. So you can imagine a 6-year-old gentleman with decompensated alcoholic cirrhosis who's been in and out of the hospital for months between CTU and the ICU, and has now been in the ICU for several weeks with multi-organ failure. The medical team at this point believes that the patient's not going to survive this ICU stay and recommends to the family withdrawal of care. The family in this scenario doesn't want to and wants to continue to persist with ongoing intensive care. So unfortunately, in scenarios like this, I find when there's a bit of friction between families and healthcare team about ongoing care, a lot of the family's time ends up being focused on these medical details, on legal aspects, on having meetings, and they're spending less time with their loved one who's probably inevitably going to pass away. And so when I recognize this happening, I try to do a few strategies to kind of shift focus. I usually like to give the family some space. So give them a few days, not force them to have meetings, not kind of talk to them every day if they just want space to process. I like to acknowledge that I don't personally have an agenda, and although I foresee an outcome for the patient, I'm not feeling like I need to make that happen now or tomorrow. And I like to acknowledge for myself that this is obviously a grieving family who's going through something really difficult, and that creating and adding friction to an already difficult scenario will only kind of taint this dying process for patients and families more than it already is difficult. And then finally, I like to reframe death sometimes for families and remind them that oftentimes people will die without warning, without the chance to say goodbye. And in the setting of a patient in the ICU, when there's kind of a planned time to withdraw care and move towards comfort care, it allows a little bit of control, and it allows the family to ensure that they can be at the bedside and be with their loved ones as they pass away. And so I find some of these tactics can be helpful when the focus is shifting more towards the medical details and legalities and away from just providing care and love to the patient. So we'll talk about a few ethical considerations. How we respond as healthcare providers to requests from families for ongoing life-prolonging interventions when we believe those interventions are not appropriate has many different considerations to take into account. So first, I'll just kind of review some of the perspectives of different parties involved. So the first is the patient and their substitute decision maker. So as I mentioned before, it's important to have had early serious illness conversations and clearly outlined the patient's goals of care. What are their wishes? What are the trade-offs they're willing to make? And what are their fears? When it comes to the family, I find there's often a component of guilt that comes into play. And this can be a guilt about not doing everything. So when we say to families, we can do this, like, what do you think they'd want? It puts a lot of weight on their shoulders. And so I try to reframe it and say to them, I'm going to take that weight off your shoulders. We're going to make this decision together. And again, remind them that just because we can do all of these things in medicine, it doesn't mean it's the right thing to do for your loved one with significant frailty and comorbidities. Similarly, I think guilt can come into play about doing everything. And so sometimes I find there's patients who have been admitted to the ICU for several days or a week, receiving full kind of aggressive care. And when you eventually bring up the idea of moving towards comfort care or palliation, families often feel a bit of a relief that, oh, you know what, my mom would never want to see herself like this. She would never want to be like this. And so it's important to recognize that guilt can come into play in many different ways for family members. From a physician perspective, when we come into these conversations around withholding and withdrawing life-sustaining treatments, I think every physician is shaped by kind of their recent experiences that they've had, and can recognize that will have an impact on kind of the future cases that they see. And so just remembering that it's okay to ask for a second opinion, and especially in times when there's conflicts with families, that's the right thing to do, is to ask for a second opinion and have that documented in the chart. It's also important as physicians that we balance sort of the stress of the healthcare team, and that can be when, for example, care is escalated maybe inappropriately, or when care is not escalated and somebody has to care for a patient who's probably going to pass from their underlying natural disease process. And then from a societal perspective, in terms of resource allocation, of course, this becomes especially important in a scenario where resources are scarce. But ultimately, we need to ensure that we are providing kind of our limited critical care resources to patients who we deem will actually have a benefit from it in the future. So when we talk about withholding and withdrawing life-sustaining treatments, I kind of like to think about it clinically, legally, and then ethically. And all of these factors have to be balanced together. So clinically, these two concepts can be conceptualized similarly. So for example, withholding the next run of dialysis would be similar to withdrawing dialysis in the future. Or withholding the next dose of a medication could be synonymous with withdrawing the medication altogether. So clinically, there may not be a huge difference between withholding and withdrawing, depending on how you look at it. Legally, it gets a little bit confusing, and it can be province to province, dependent on provincial guidelines. So in BC, there's not really any legal precedent or cases for withholding or withdrawing life-sustaining treatments. Our basis for kind of being able to withhold non-beneficial care is based on kind of multiple other precedents in medicine. And so a surgeon is not forced to operate on somebody that they don't deem as a good surgical candidate. An oncologist is not required to give chemotherapy to someone who they don't think would benefit from the chemotherapy. And a nephrologist doesn't have to offer dialysis to somebody who they do not think is a good candidate. So similarly, from critical care perspective, we don't have to offer someone admission to critical care if we don't feel that it's in their best interest or within the standard of care. When it comes to withdrawing life-sustaining treatments, practically, physicians generally act in accordance with the rulings of the Rasuli case, which is that consent is required to withdraw life-sustaining treatments. And then ethically, I think this depends a little bit on physician to physician. So generally, most physicians feel more comfortable withholding life-sustaining treatments because it's a bit more of a passive act, whereas withdrawing life-sustaining treatments is very much an active act of omission and of taking something away. And so, again, this often depends on how each individual physician feels with regards to withholding and withdrawing. Now, when we think about withholding and withdrawing in this way, it kind of begs the question of, like, can you really do a trial of ICU? And so we get asked this question a lot from families. Can you just take them to the ICU for a few days and just try a breathing tube and try keeping them in the ICU for a few days? And so although this is a common request, it's not truly legally possible based on the framework in which we practice. So we can unilaterally withhold care that we don't think is appropriate, but once it's begun, we need consent to withdraw. And so while it is a good idea and a good concept to be able to do trials and to try to find out which patients will benefit, in practice, it becomes a bit more difficult to actually withdraw care when it's not proven to be beneficial because of the legal precedent that's set. So when we talk about withholding or withdrawing life-sustaining treatment, it's always in the context of treatment that is felt not to be beneficial or treatment that we feel is harmful. And so we have to ask ourselves, well, what does it mean to be beneficial? Like, how do we define a benefit? And so there's many different types of benefits. So one is a physiological one. So for example, a patient's blood pressure is low. We put them on levofed, their blood pressure comes up. There's a very clear physiological benefit. The avoidance of death. So a patient's in respiratory distress. They're in extremis, they're intubated, and without that, they would have passed. So we've avoided death. The next is quality of life. This is obviously a complicated one, which we'll get into a little bit. But we put patients through long hospital stays and ICU admissions with the hope that they return to a quality of life that is acceptable to them. And then finally, the idea of justice, which is a hard one to bring up with families, but that we probably have in the back of our minds about how to allocate these scarce resources that we have to achieve the greatest benefit. So when we talk about quality of life, this inherently applies a value judgment and varies from person to person. It's quite subjective, and ultimately culture, religion often play a large role, and we see that here in hospital. It's important as physicians that we don't impose sort of what we think is an acceptable quality of life onto our patients and their families. And especially here at St. Paul's, when we work with such a vulnerable patient population, we have to make sure that we don't treat our patients differently or offer different levels of care based on our perception of their quality of life. So there's been a shift towards patient autonomy, which I think is an important shift to acknowledge patients' role in their healthcare and the importance of their values and judgments coming into play with healthcare decisions. But ultimately, the kind of concept of autonomy often comes into contrast with the concept of justice. And autonomy is simply one factor that we have to consider. So even if a patient's demanding a certain level of care, it does not oblige the physician to offer that treatment if we feel like it's outside the standard of care. And so what we need to be sure of is what is truly the standard of care. And so this would be something that a physician of similar experience and training would offer or not offer in the same scenario. And of course, this is going to be in an ICU population where patients are very heterogeneous and there's huge variability in practice. The standard of care will vary physician to physician and institution to institution. And so when we say that ongoing care or escalation of care is considered to be non-beneficial or medically inappropriate, we have to be pretty darn sure that nobody else would offer it and that it's truly outside the standard of care. And in scenarios when we're at these kind of intractable conflicts between healthcare providers and the patient's families, there's some good questions to ask ourselves. And so this is from the American Thoracic Society's kind of joint policy statement on how to respond to requests for potentially inappropriate treatment. And these are just some good questions to go through when we're in these scenarios. So to make sure we're doing the right thing for the patient. So am I certain that this request, the requested treatment is truly outside the boundaries of accepted practice? Would I be willing to have my decision or my rationale displayed publicly in court? What are the consequences to the patient, surrogate, or team as a result of implementing my decision? Am I sure that sex, race, socioeconomic status, and other psychosocial factors are not entering into my decision? And so I thought this was a good review of questions to ask ourselves to make sure that we're making decisions for the patient in the right way. So we'll take a pause again and just talk through a case and kind of put some of these policies and guidelines we just reviewed a little bit into practice. So you can imagine a patient who's in their 80s, they come from long-term care, have dementia, a history of strokes, a MoCA score of 12. At baseline, this patient's bedbound or wheelchair-bound and eats at risk, chronically aspirating. She comes into CTU and is admitted with an aspiration pneumonia, and her goals of care status hasn't been reassessed yet. She comes in as a full code. So her oxygen requirements are increasing, and the family is demanding that the patient goes to ICU for intubation. So in this scenario, I think we'd probably all agree that escalating care would probably not be beneficial for the patient and likely impose just further harm. And so in this scenario, if it's felt that escalation of care is outside the standard of practice, to review the steps that we should follow. So one, we need to get medical consensus. So get a second opinion from another colleague and have that documented in the chart. Risk management should be involved when there's tension or disagreement between families and the healthcare team. Ethics could be involved. The family should be notified clearly that there will be no escalation of care. This should be documented in the chart. And then ultimately, the care team can change the code status unilaterally to a DNRM 3, saying that not for ICU, not for intubation. Now, these scenarios are obviously challenging and often, I think, can be avoided if we have early serious illness conversations with patients and their families. We've probably all seen this before, the Serious Illness Conversation Guide from Harvard, that tells us how to have these conversations, how to set up the conversation flow. And we've obviously heard some of the benefits of having these conversations early in terms of avoiding these difficult conversations in an urgent manner at the end of life. So this kind of segues into the research project that we've been working on here at St. Paul's, where we asked ourselves, how are we doing here at St. Paul's with having serious illness conversations? And so we did a review in 2021 that basically looked at patients who were admitted to the hospital with high mortality. And so we used a Charlson comorbidity index, and we said if their index was greater than 3, this would indicate the patients have a high mortality, they have serious illness, and they warrant having a serious illness and goals of care conversation during their hospital admission. And so what we found is of the patients who met this criteria, those in MSJ, 70% of them actually had a conversation, which is pretty good. At St. Paul's, it was 26%. So we're not having these conversations with patients who have serious illness and advanced disease. And so we had to ask ourselves, why is this happening? And what is it about here at St. Paul's that we're not having these conversations? I think a part of it is that we're dealing with a very vulnerable population and a population that often lives sort of day by day, month by month. And sometimes it feels out of touch to be asking them their ideal plan for death or their ideal goals at the end of life, when really they're trying to figure out how they're going to get their next meal or where they're going to stay that night. And you realize it's a bit of a privilege to be able to talk about end of life in kind of in a calm way where, other families would say, oh, I want to pass away at home with my family. But oftentimes our patients don't have a home to go to or don't have family support. And so we wanted to know how we could actually have these conversations with this specific population at St. Paul's to best provide them with the end-of-life care that they deserve. So we've started this qualitative research project where we've gone around and we've been interviewing patients who fall into this specific category of, or the specific population at St. Paul's. And we're trying to understand from them their experiences having goals of care conversations. So the patients we're hoping to include in our study are those who are followed by the addictions medicine team, and so therefore have some sort of substance use disorder. They experience some sort of structural vulnerability, and so this could mean they live with no fixed address, they live in shelters, they live in an SRO, or live somewhere on the downtown east side. and then they have an advanced serious illness. So our hope is that through this qualitative research project and through our patient interviews, we can understand the experiences of patients having these conversations and what their needs and preferences are during a serious illness conversation. So we're going through this cycle here of speaking with patients, transcribing our interviews, looking through some of the themes and ideas that come up in terms of what these patients want, and then looking back at how we're asking these questions and if we're getting the right information. And we're hoping that in the end, we'll be able to improve end-of-life care for this very vulnerable population and hopefully develop some sort of patient-centered best practice guide that may be similar to the serious illness conversation guide, but specifically for patients who are vulnerable, like we see here at St. Paul's. Okay, so that's the end. I'm just going to go through a bit of a summary, and then we'll open the floor to discussion. So I'm hoping now everyone can kind of understand some of the differences between withholding and withdrawing life-sustaining treatments, and recognizes there's different legal, ethical, and clinical factors to balance. I hope we all can know about some resources that are available to us for the idea of withholding and withdrawing life-sustaining treatments, both at St. Paul's kind of level and then also on a national level. And then finally, I hope we can all understand the importance of having early serious illness conversations and preventing some of these intractable conflicts on potentially inappropriate care. I've got a bunch of thank yous for people who helped me with this, my references, and then questions, discussion.
Questions for Dr. Schon? Dr. Peets.
Excellent presentation, Emma. Thank you very much. I really liked your focus on communication and starting it off early. While we're pending the results of your current study, do you have any suggestions for us as to how we can facilitate early communication and getting those conversations going now based on your reading or personal experience?
Yeah, so we've done a couple like preliminary interviews with patients and to kind of understand their needs and preferences during these conversations. And it's like what they say is like seems very obvious. It's like, oh, we just want people to talk to us and give us the truth. And we want people to just be like open and honest with us. And we want people to feel like, I just want to feel like my doctor cares about me. So it's like very obvious things that we should be doing. And when I heard them, I was like, oh man, are we this bad? Like we're not like speaking in a compassionate way. We're not like giving them the honest truth. Like we're like shying away from these conversations. And so ultimately what we found so far is like very basic things that this vulnerable population, like anybody else, would want.
Comments, questions? Yes, sorry. Please.
Hi, thank you so much for your presentation.
Could you use the mic? Could you push that, please?
Thank you. Thank you so much for the presentation. I really appreciated many parts of it, especially hearing about how you address folks at the beginning of an ICU stay with those multiple potential options. That was really helpful to hear. I'm a social worker, full disclosure. And so I just wanted to bring some attention. I think, I mean, clearly there are many disciplines that you work with in your interdisciplinary team, but particularly in this area of practice, your social workers within Providence are resources for TSDM identification, supporting those conversations, risk assessment, ethical analysis, and navigating conflict. So in terms of when you're escalating to risk management and ethics, please do consider involving a social worker as a preliminary step to help address the latter parts, because we can certainly help you. Thank you.
Yes, no, thank you. That's so true. I find the social workers in like the ICU are like so important because oftentimes patients come in and they're not identified, and then we need help identifying them. And then it's about finding family to help make decisions on their behalf. So yeah, we definitely couldn't do any of this without the social workers.
Other questions? Yes, please.
Hi, thank you. I just have a question about, so you were just mentioning now from the other question that what patients may perceive and what they want from these conversations. Have you ever seen a disconnect between what physicians report that they have discussed and what patients think that they have received? And why is there a disconnect? And why there may be a disconnect there? I think I've even read that myself, but is there ways that we can reduce that gap, even if a physician thinks that they were compassionate, et cetera, et cetera?
Yeah, absolutely. So like for our project, we're usually kind of picking patients who have a code status that's not full code. So they're either like a no CPR or they're like a not for ICU. And so that should imply that they've had a conversation about this. And like, it's maybe not surprising, but oftentimes I'll be like, so I noticed your code status is a DNRM3, which means you wouldn't come to ICU. And they're like, oh, what? I would want absolutely everything done. And you're just like, okay, so whatever happened in that conversation, if assuming it happened, like clearly the patient did not absorb what went on. And so why? It's hard to know. Obviously, there's many factors that could come into play. I think one of them is like a lot of times we're like really rushed in having these conversations. We don't feel like we have time to maybe make it a full conversation. But I think something we can do probably more is like check with the patient their understanding. Like, can you repeat to me what I've said to you? Like, do you understand the implications of this decision? And really checking to make sure they get it. Because oftentimes I think we just kind of give them this information, they like kind of nod yes or no, and then you go document it in the chart, but they don't actually fully understand it themselves. So I think checking would probably be one step what we could do to make sure that we all are understanding what the outcome is of a conversation. Yeah.
Yes.
Can I make a response just a little bit around, like, I mean, I don't have to tell you guys as physicians, you know this, but you know, when the cortisol is running and our executive function checks out, so as a family member in a critically, or a patient in a very high intensity situation, our ability to understand and listen and pick up on the main cues within a conversation is limited. So certainly social work functions as a debriefing mechanism as well with the patients and families, so please do use us for that. And really it's repetition and talking on a level that they can understand. So.
No, that's so true. And also having, if the patient wants a family member there or a friend there to help absorb the information and write things down for them, that can also be really helpful to help with retention.
Thanks, Emma. A great summary of the challenges here. I'll just note in addition to your comments about how to have these conversations with folks living with structural vulnerabilities, we have created a guide and a tip sheet sort of in advance of the beginning of this study that can be found on PHC Connect under advanced care planning and serious illness conversations. So there's quite a variety of tools and kind of recent adaptations of the serious illness conversation guide for various settings, including with the substitute decision maker and so on. So this is an area of research that's of interest to a lot of clinicians, I think, nationally and across the US as well now. And certainly it's an area that we've been focusing on here at PHC. So there are tools and resources I'd encourage you to look at if you're interested.
Thanks, Wallace.
So I just have a comment. As I was sitting listening, I think we were all absorbing and learning. Grand Rounds is a place for me to learn. And I don't know if the rest of you learned anything today, but there were points that I didn't know or you clarified. And yet we do this all the time. The other side of in this script are people who never do it, people we're talking to. So we have a checklist of things that we're thinking about and how to go about it. We have a clinical checklist, we have a legal checklist, we have an ethical checklist. And then we talk to the other people who have none of this advantage. They haven't seen the program.
Yeah, that's a good point.
How do we make the program? And it's not to argue with this, but how do we set the stage for for people who have these problems? And I have, but how do we? It's not to educate, but here's where we come from. Mm-hmm. We've been practicing. We've done these scenarios. We've lived them. And yet we're talking to someone who has none of this. Any ideas on that?
Yeah, I mean, I think that just highlights the importance of like these conversations starting early and like in an outpatient setting. So like family doctors, like primary care providers, oncologists, setting the scene for these conversations, saying, yeah, you have this new diagnosis of cancer and we hope we can cure, but if not, here are conversations that may come up in the future, and kind of setting that stage early. I think that's probably one strategy. And then the other one, I guess, when we're having these conversations in hospital is when you go to have the conversation, like tell them, like, can we have a conversation about the end of life, and just acknowledge that that's what the conversation will be. Because otherwise I find, patients get kind of thrown off. They're like, oh, we're talking about this? I didn't know this was going to happen. And they're kind of like then totally stressed and aren't absorbing what you're saying. So maybe just acknowledging at the beginning of a serious illness conversation that we're going to talk, is it okay with you if we talk about some of these difficult conversations? But you're right, we're coming in knowing exactly what we're going to talk about or how we're going to do it. And they're coming in just not knowing at all what to expect.
Great. Any other questions or comments?
Dr. Schon, this is Barry Chan from General Internal Medicine. Thank you very much for your talk. It's very informative. My question to you is more practical about getting that second consult, right? I actually find that I don't know how to go about that. Sometimes, yes, there may be a very specific specialty that you can hunt down and say, hey, oncology, you've been treating the stage 4 cancer. It's here now. Can you make an opinion about prognosis, etc.? Right? Sometimes. But sometimes there is nothing obvious, right? So would it be reasonable, and that I find this is actually majority of the CTU patients, is sometimes the second opinion comes from when we consult critical care, not necessarily for medical treatment as a consultation question, but just from a goals of care perspective, prognosis assessment.
Yeah, no, I hear what you're saying. Because sometimes on CTU, you know that it's probably not appropriate to escalate, but when families demanding it and asking for it, do you call and ask for a second opinion? And I guess I've definitely seen that happen before, and maybe I opened it to some of the other intensivists in the room, but I don't think it's unreasonable in the setting of disagreement with family to call the outreach team, the ICU physician on call, and say, hey, do you mind coming by for a second opinion on putting limits on care? And I don't think that any of us would feel angry or disappointed or that that's not appropriate. I think that that's totally appropriate, especially based on the St. Paul's policy I just outlined, to ask for an opinion and have someone else come document it from an ICU perspective. I don't know if
I think that I think we would consider that as offering our expert opinion in the same way as you would ask for a consult from cardiac surgery for a patient who again you might not think should be a candidate, but for the same thing we are able to offer that expert opinion, and certainly we would rather do that before the crisis happens and before the code is called, for sure.
Yeah, good question. Thank you.
Thank you.
Any other comments or questions? If not, thank you, Emma.
Thanks, everyone.